Richard, without further ado, can I ask you to explain what the STP is and what the STP can do for you?
Good afternoon, ladies and gentlemen, and thank you so much for coming today. And a massive thank you for your continued commitment. It's always a pleasure and a privilege to be in the Fairham and Gosport public meetings, because we do get such a good and vibrant process. I'm happy to take questions as we go through, but if they're quite complicated questions, then please leave them for the end and we can pick them up. I will be quite rapid because I'm mindful of time, and therefore won't go over everything in a huge amount of detail, but we'll give you a chance to, thank you, we'll give you a chance to ask questions at the end. Just a question for the audience. How many people have heard of these things called sustainability and transformation plans? Just a show of hands. A number of people have heard of them. Yeah, and the board will, and the governing body will clearly need to. And I suspect that you've heard about them as a kind of almost a threat or a risk to the local health services, because they haven't been particularly well reported nationally as a process of change. So my job today is to explain what they are, how they've come about, and what are they seeking to achieve. So a little bit of background very briefly. 3 years ago now, 2014, we had the publication of the NHS 5-year forward view, which was, I think, a really very clear, very simple, very short document which described the strategic challenges in future for health and care across our population. And it described some challenges and some gaps, some quality gaps, some financial gaps, and some gaps in the way in which we prevent people falling ill. And move forward to 2016, the ministers and NHS centrally started to ask the question, why is it that this strategy was so well received? Are we still not seeing in local systems the implementation of some of the changes that everyone said were great ideas? The new models of care, the adoption and implementation of prevention still really weren't happening consistently across the country. And one of the answers given was, when they came out and talked to local people and local teams, was, well, the NHS is quite complicated, it's quite fragmented, lots of organisations doing lots of things under lots of pressure, and actually getting a clear collective commitment to deliver transformation and change is a big ask, and it doesn't happen overnight, and it doesn't happen without some form of coordinating function. And that's where these things called sustainability and transformation plans came about. They were a means of galvanising the local health and care and voluntary sector partners to work together to describe what the future of the NHS and local government in terms of health and care will look like over the next 5 years in partnership with local people. So the first thing we did was recognise that there was a huge amount of work being done locally that we could draw upon, that have been working with local people for many years. We have many pockets of brilliant process. We have the men's shed, we have emerging same-day access services in Gosport, we've got innovation left, right and centre, but they're typically small pockets of innovation, small pockets of best practice, not drawn together to describe a very clear model. So what we did, we went out and looked at what were all the elements of best practice and innovation across Hampshire and the Isle of Wight, which is the footprint that we were working on. And the next is we looked at what the challenges we were going to face over the course of the next 5 years. For the first time, certainly in my time in the NHS, and Andy, I'm thinking first time in the last couple of decades, we had a long-term view of what our financial allocations were going to look like. So 5-year financial allocation. And that was great, because for the first time we could then predict how much money we were going to get, how much cost we were going to incur if we deliver services in the way in which we do, and what do we think the gap might be around our funding and our service model. And that told us 6 things. And hopefully you've got your presentations, you'll be able to see them. The first thing it told us was that we have a real challenge around workforce. Not that our workforce aren't excellent and great and well trained, but that the way in which we provide services at the moment already creates gaps in a number of professional, clinical and other working groups. So, for example, domiciliary care workers are already in very short supply, and if we continue to grow the way in which they're deployed and used in the system, we'll see about 28% shortfall in domiciliary care staff over the course of the next 5 years. General practice, and a number of our GP colleagues around the table will tell you, in Gosport, for example, it is already hugely challenging to secure or retain general practitioners working. Over the course of the next 5 years, we anticipate that about 30% of practices will struggle so significantly around the recruitment of general practitioners that they will no longer be viable. So that really posed the question to us: can we continue to operate business as usual in the knowledge that our nursing, our therapy, our medical, our professional and our support staff workforce were not going to be there in 5 years' time? We have 12,000 vacancies in the NHS in Hampshire and the Isle of Wight at the moment, and that's about the same as the number of school leavers leaving our schools every year in Hampshire. So we'd have to recruit all of those trained and ready to work just to cover off the gap we face today. The second challenge we recognised was the healthcare today is reactive. We've traditionally used the model of allowing people to choose when and how they interface with the NHS, be they go and see their GP, go into A&E, access a 111 service, go and see the community pharmacy, but it's typically reactive. Someone waits until they fall ill and then go and access services. And that actually was a sustainable and tolerable model in the 1970s and 1980s, when we didn't see people with many long-term conditions, illnesses which are chronic and last a lifetime. But as we begin to see more and more people who have conditions such as diabetes and chronic obstructive pulmonary disease or respiratory diseases and heart disease, that becomes more and more unsustainable, because people with multiple physical and mental health conditions are presenting more and more frequently in crisis, requiring access to healthcare. And that's not doing them a great service, and it's actually consuming a huge increasing levels of resource to help treat people in crisis, rather than predicting when people might be feeling poorly and how we can then help people to remain healthy and independent. The other reflection is that we used to be worrying about unmet need, and we still have people in our community who we do think have needs that are not being met. But increasingly we're slightly worried about the burden of care that we're imposing on people in our community. So if I personalise it, I cared for my father over the Christmas period, who is on 16 different medications, and it took us about 45 minutes to safely take all of those medications with complex gizmos opening doors to give him the medication. And I posed the question to him: what benefit does the 13th, the 14th and the 15th medication give to you? Do you understand what it's doing and what value does it add? And he said, I have no idea. Someone told me I have to take it, and lo and behold, I do take it religiously. And then we reflected on the number of times he was going up to the different hospitals, 3 different hospitals, and his GP practice. And we realised that actually the burden of care that he was having to go through to access constant blood tests, GP visits, secondary care, the rheumatologist, the diabetologist, the neurologist, all giving him advice and support, was a huge burden on him and affected his life considerably. Whereas actually, had everybody worked together and sat down with my father, I'm pretty sure that the 12th, 13th and 14th medicine was not going to add as much value, and the trip to the hospital probably could have been done by a telephone call. And so the burden of care is something that you've now told us, this is becoming overwhelming for us, and we want to think of a different way of doing things. And then finally, people continue, you've consistently told us at this table, it is very confusing to access services. There are lots of different points of entry. You wonder why. You can shop online, you can do your banking online, you can update your car tax online, but for some reason, in many instances, you can't consistently manage your medical records on your computer or your smartphone. You can't update your symptoms, you can't update your observations yourself online and manage your condition more effectively. And some people can, and that's brilliant, but not many people in the NHS can. So driving that kind of empowering individuals by offering them means of using technology to care for themselves and manage their own condition is the final recognition of one of the great challenges we have to adopt in the NHS. And finally, I will talk about money, because money has nationally been talked about as a major constraint. And I will say that the NHS now is slightly different to local government. What we do know in local government is there are real terms reductions in spending required of them by central government over the course of the next 5 years. And that is an immediate and very significant cost pressure on the services. But for the NHS, I think there's a bit of a belief that the NHS is having to take real money out of our service provision. So the answer is, what we know over the next 5 years is that across Hampshire and the Isle of Wight, we will see about £1/3 billion real term investment in the health sector, which could be a cause for celebration, if only that the way in which we work at the moment will inflate our cost base by about £600 million over the same period. So what we will get is real growth, but what we'll be left with is, if we do nothing else, is we'll be left with about £500 million worth of unmet cost in our system. So it requires us now to think about how we will work differently. So we, yes.
You say £1/3 billion, that's 300 million, isn't it? Or am I going?
Yes, 330 million.
Yeah, well, that's not a lot, is it?
It's not insignificant.
It sounds more when you say £1/3 billion. This is hype, isn't it?
Okay, or 330 million.
Yeah, I'll prefer that.
Fine, okay, I'll use 330 million. So the question about how do we solve these issues, there are some areas in the country which have taken, I think, an approach of looking at this from the top and seeing what should we impose on local communities. The approach we've taken, given Hampshire is quite large, is we've looked at the bottom and we've said, what are the approaches that have been worked up with local communities and local citizens that people feel they want? And there we've got the My Life a Full Life programme on the Isle of Wight, the Better Local Care programme that we've been running in Fareham and Gosport over the course of the last 2.5 years. And the role of the transformation programme across Hampshire and the Isle of Wight is not to tell those local transformation programmes what to do, but is to ask the question, is there anything that you need to do over and above that you're doing in Fareham and Gosport that we can help with at a level of Hampshire and the Isle of Wight? And typically the answer that local systems have told us is that we think by working together around prevention, we can do a better job and have greater impact than every little community working on their own. The second thing that the communities have told us is we've made great strides in reimagining how integrated primary and community services could work, but actually there are still lessons we could learn together. So don't tell us how to work, but help us identify the best models of care, the best way in which GPs, diabetologists, respiratory consultants can work with local people to create single services. We think that there are some standards we should be setting that ensure consistent ways of supporting people through the acute hospitals and into a discharge into a home setting. And that's what we call the kind of effective patient flow and discharge, because we still have too many people awaiting discharge in our acute hospital settings, being cared for in an inappropriate environment. The fourth area that collectively local systems said was, we really want to think differently about acute physical health. Now, again, another show of hands, who has seen and observed the vascular surgical debate playing out at the moment. It's probably a familiar story that you've heard, and it's probably felt for you as members of the public a bit deeply confusing. Is this a battle for where the service is delivered? Is it Southampton or Portsmouth? Is that the case? Almost an adversarial debate going on about where the service is delivered. The answer is that the discussion we've had about vascular surgery is actually a precursor to a debate we'll start to have around a range of hyperacute, very specialised acute services. Because, as an eminent surgeon from Basingstoke was saying just the other night, medicine 10 years ago is very different, or surgery 10 years ago is very different to surgery today. If people came in with a heart attack in the hospital 10 years ago, they might be managed by a junior and then seen by a consultant in the morning. Now they're seen by a consultant irrespective of what time they come in. But to do that, you need to have consultant rotors operating 24/7. You need to have the best equipment, the best technology, and you need to do the very best outcomes for local people. And as we become more and more specialised, we start to introduce thrombectomies for strokes, we start to introduce the latest investment in technology and processes. The debate will consistently be how and what population do we need to serve in order to guarantee 24/7 access to the very, very best specialist care. And as a consequence of that, rather than going down a competitive approach, Portsmouth Hospitals Trust, Southampton, University Hospital Southampton, and the Isle of Wight have said, let's not fight about who does these things. If we have a robot to do laparoscopic urological surgery in Portsmouth, let's make sure that's available to everybody across the Solent region. And if we've got expertise in UHS, let's make sure that's available to everybody in a partnership. And that's really what the partnership is about. The Acute Physical Alliance is about making sure that the assets and skills across the 3 hospitals in the Solent area are available for everybody in their local area where possible.
Excuse me, I can see the sense of that, but looking at where we are, Southampton, Portsmouth and the Isle of Wight, poor souls, have got to get across the Solent. Access isn't just having the pathway to the consultant or something, but if you're talking about a heart attack or something like that, it really depends on whether the M27 or the other roads are blocked. So whilst it might make sense for a particular area of expertise to be in Southampton or Portsmouth, if you are living near the Southampton and you have to come all the way to Portsmouth, or vice versa, and the M27 is blocked, which it quite frequently is, that is really important. So accessibility, I think, needs to be considered.
So you couldn't be more right. And what I'm not signalling is that we're going to move hordes of patients, vast numbers of people to services. What I am signalling is that we will be working in collaboration so that if we have 24 urologists across the 3 hospitals, what we do is we make sure that those urologists will work together to make sure that locally on the island or Portsmouth or Southampton, we're creating locally responsive, accessible services for people. But and if we've learned something, we've learned an awful lot from the major trauma centralisation. We've saved 1,000 lives by centralising major trauma at University Hospital Southampton, and that's an incredible statistic. In the last 2 years, 1,000 people have been saved who probably would have passed away had we not brought the strength and expertise of all the specialists together 24 hours at University Hospital Southampton. So I think it's absolutely that local access point, which is what people want, using the connection of the totality of the clinical teams rather than each hospital having to fend for itself.